Greetings from Johns Hopkins All Children's Hospital. My name is Dr. Paula Dees, and on behalf of our team, we'd like to share our experience to date with developing a predictive model to help reduce 7-day respiratory readmissions at our freestanding children's hospital. There is increasing regulatory pressure at both state and federal levels to prevent and reduce readmissions. Unfortunately, little is known about how to safely accomplish this. Our approach was multifaceted. While many of our efforts were focused upon improving communication, we ultimately sought to identify patients at higher risk for readmission before they were ever discharged. Our team developed a deep learning neural network for predicting 7 and 30-day readmissions. The model takes data directly from the electronic medical record and compiles a risk score for each patient. This information is then emailed in a report to our clinicians every morning prior to rounds. Our model had an area under the curve of 0.76. The truth table showed the results of testing the model for 3 classes. Class 0 is no readmission, Class 1 is 7-day readmission, and Class 2 is 30-day readmissions. The development of this model provided a unique opportunity for our team to not only evaluate how to implement a tool, but also assess its performance against the clinical intuition of our providers. We aimed to prospectively assess the risk stratification agreement between our hospitalists and the repeat algorithm. Prior to implementing the model, we asked the hospitalists to assess their patients as a high, medium, or low risk for readmission using percentile cutoffs similarly assigned by the model. Overall, the provider and machine learning tool provided an equivalent assessment of risk in 52.8% of patients. There was only slight agreement between the provider and tool as measured by a Cohen's kappa of 0.104. 7% of patients in the study had what we deemed a clinically significant disagreement between low and high risk of readmission. Therefore, the overall agreement of the readmission risk stratification was poor. 53% of providers said access to a readmission risk score was at least somewhat likely to influence their decision-making at the point of care. This suggests there may be limited phase validity of our repeat tool. We assess the performance of man versus machine in designating patients as high risk for readmission. Both the provider and the tool's assessment had low practical sensitivity and positive predictive value for all readmissions in this exploratory analysis, although the tool's performance was better. However, the results are limited by the small sample size and future more adequately powered studies are necessary. Overall, the use of a predictive model alone is likely insufficient to change 7-day readmissions on a pediatric medicine service. Hospitalists may be open to using a predictive tool if the information is timely, readily accessible, and easy to navigate. A predictive tool can augment a multidisciplinary approach to proactive discharge planning. Thank you so much for your time and attention. Be well.